we will be starting the most important session of this free paper. There's a Colonel Rangachari Award session. There's the most coveted prize which you are all looking for as a researcher in India. So there are several rules. The presentation 5 minutes, and there are 5 columns are there. One is the content, presentation, slide quality, originality, and total is 100 marks. So each specialty you have one topper has come, and this will be the final round. 18 candidates are presenting. So stick to the time because there is a negative marking for the time. So we'll start. Somebody call the first. Okay. First we'll start with cataract, and presenting author is Dr. Tanmay Vaidya, who will be talking on capsule phimosis and retinitis pigmentosa, role of capsular tension ring, polishing and biomarker analysis. You start your presentation.
Good afternoon, everyone. None of the authors have any financial disclosures to make. So retinitis pigmentosa is a group of retinal inherited disorders which present with visually debilitating symptoms for the patient. On top of that, these patients develop a cataract, which is early onset. Now, cataract surgery is a real blessing for these patients because that will restore the central vision loss. But the only problem, the incidence of post-operative complications, especially capsular phimosis, is very high in these patients. This is because of the zonular dehiscence and increased lens epithelial fibrosis, which is because of the blood breakdown in the blood retinal barrier. And as you can see, it's an aggressive phimosis. You can literally see the IOL being crumpled up inside the bag. So we decided to study the role of a capsular tension ring and anterior capsular polishing to prevent capsular phimosis in these patients. We also wanted to know why exactly this phimosis is occurring. So we decided to analyze the levels of biomarkers as well. We included patients, RP patients having bilateral immature cataract. We excluded patients having a mature cataract or any other ocular comorbidity. We did a prospective interventional study, and after getting the ethical committee approval, we recruited 20 patients having bilateral cataract, that is 40 eyes. After clinical evaluation and ancillary investigations, cataract surgery of the first eye was done with the intervention and the second eye without the intervention. Aqueous humor biomarker analysis was also carried out, and these patients were assessed at 6 months for the capsular phimosis. Now, these were the surgical steps. First, the aqueous humor was collected before the surgery, that is, before we started with the cataract surgery steps. Capsular tension ring and capsular polishing was done in the first eye, and in the contralateral eye, no additional intervention was carried out. This was done by a single surgeon. The CCC size was maintained at 5 millimeters, and a hydrophobic monofocal acrylic foldable IOL was implanted in the bag. We assessed the patient at 6 months using slit lamp examination, where we measured the least diameter of the anterior lens capsular opening. When this was less than 4 millimeters, that time we considered the patient to be having capsular phimosis. We also assessed the biomarkers using a multiplex ELISA technique by flow cytometry using a BD-FACS Canto 2 machine. At 6 months, only one eye where we implanted the CTR and did polishing showed significant phimosis, whereas 5 eyes without the additional intervention showed phimosis. So it was approaching statistical significance between both of the groups. Now coming to the biomarkers, we see a rise of pro-inflammatory and pro-fibrotic markers in the RP patients. And I would like to remind, this is before the cataract surgery. So after doing the cataract surgery, all these markers are going to shoot up further. I would like to focus on these particular 3 molecules. These are also implicated in systemic conditions like cystic fibrosis in the lungs and the heart also post myocardial infarction. Now, there is no cure for these conditions as well, but few drugs which are antifibrotic like pirfenidone have been shown to slow down the progression in these cases, so that can hold a promising future in such patients. At the same time, anti-inflammatory markers were significantly reduced in these patients. So all in all, what we saw is that there was a synergistic correlation where pro-fibrotic factors and pro-inflammatory factors were increased and anti-fibrotic factors were reduced. So this will lead to the aggressive and early onset phimosis in such patients. Now, this wasn't exactly the objective of our study, but what we also saw is that patients with early RP changes showed the borderline values of these markers, and there was lesser incidence in such patients, whereas in the advanced RP changes patient, it was significantly more. So to conclude, what was known was that in retinitis pigmentosa, capsular phimosis plays a huge role in the post-operative outcomes. What this study added is that placing a CTR and anterior capsular polishing will reduce the incidence of phimosis. At the same time, there is an increase in the pro-fibrotic factors, like I said, and decrease in the anti-fibrotic factors, which is leading to the increased incidence of phimosis. And the severity of the disease also plays a huge role. Now, what we exactly want to do in the future is to develop efficient intraoperative techniques to improve post-operative outcomes. There will be a huge role of targeted therapy to reduce the inflammatory biomarkers. And the final goal will be to develop a topical therapy to prevent this capsular phimosis. These are my references, my acknowledgements. Thank you so much.
Dr. Sri Ganesh, can you ask one question for this? We will restrict to one question per presenter.
The incidence of phimosis depends upon the capsulotomy size.
Yes, sir.
So there can be a variation in the capsulotomy size, and it is found that with larger capsulotomies, the incidence of phimosis is less.
Yes, sir.
So how did you exactly kind of reproduce the same size of rhexis in both the eyes? Did you use a femtosecond laser?
No, sir. No femtosecond laser was used. A single surgeon operated, and we measured the capsular rhexis size before including these patients. If it was less, we did exclude these patients, but we didn't have any such incidences.
Because the thing is, even between eyes, when you do a manual rhexis, you don't get the size exactly. And then even if there's like a 500 or 600 micron difference, there is a difference in the surface area and the contraction. Also, it depends upon the amount of myopia and the size of the bag. So did you measure the size of the bag and also the weakness of the zonules?
So high myope patients were excluded from our study, having axial length more than 25 mm, and because that itself will increase the incidence of phimosis. So we wanted to rule that out completely. So
but you did not know the bag size, because the bag size also can vary between
the bag
patients.
size wasn't calculated, so the axial length was used as a factor.
Thank you.
So next, I would like to call upon Dr. Parikshit Gogate to present his talk on prevalence of blindness and visual disabilities among 50 years and older population of Nepal.
Next speaker, Dr. Purna Chandra. Please, you be ready on the other podium.
May I start, sir?
Yes, yes.
Respected distinguished judges and learned audience, I'll be speaking on this RAP study, a nationwide survey that we had done in Nepal. This is to ascertain the causes of prevalence of blindness and severe visual impairment, to look at the age, gender, and province-wise prevalence, so that we could decide on the priorities as to how to combat blindness. Nepal is a country with unique geography, with too many rivers and mountains, and living service is difficult. This is the first time that all the 7 provinces of Nepal were studied, and we did a detailed sampling using the RAP 7 version for all the 7 provinces, and in all, nearly 33,000 people were examined for this. And when we looked at the age, sex, province weighted estimates, we were surprised to find that the blindness was 1.1%, which was much, much less than what it was reported 25 years ago. In all surveys, the blindness in women is more as compared to men. And here also there was a difference, but the difference was only 1.35 times, which is not much. When we look at the age and sex-wise weighted prevalence of bilateral blindness, again, we were surprised to find that the provinces in the Tarai region, the Madhes province and the Lumbini province, had almost double the blindness as compared to the blindness in, say, Sudur Paschim, which is high up in the mountains. So we would have thought that places which don't have many eye care centers, which are up in the Himalayas, will have more cataract, but that was not the case. So if we see these two provinces in the Tarai region are the place where the maximum number of eye care centers of Nepal are present. But even there, today, there is almost twice the prevalence as it's there in the mountainous areas. We compared this with previous studies done so far, and as you can see, in year 1998, the prevalence of blindness was 5.3%. So due to a collaboration of all the NGOs, the government, all healthcare personnel, international collaboration, from 5.3%, it has come to 1.1%. And which is all the more creditable considering that Nepal's per capita income is just $1,337. So if you will look at it from any other South Asian country, if we compare the per capita income and the prevalence in Nepal is much, much lesser. Again, when we look at the comparison with the RAB India studies, which were done, spearheaded by the RP Center, in India, it is 2%. In Nepal, it was 1.1%. So that's much, much lesser. It's almost equivalent to Bhutan, again, whose per capita income is much, much more. When we look at the causes of blindness, obviously cataract is the commonest cause of blindness, followed by retinal causes and glaucoma. Corneal causes are reducing. But when we look at moderate visual impairment, if you will see the fourth one, cataract surgical complication is also a common cause of moderate visual impairment. So we are doing a huge amount of cataract surgeries, but cataract surgery quality definitely can be improved. And again, when we look at the mild visual impairment, almost 2/3 of it is because of refractive errors. So causes of blindness, commonest is cataract. Again, for SVI, it is still cataract, but for mild VI, it is uncorrected refractive errors. This is what we have seen from all other studies done from Southeast Asia. So in the end, I would like to conclude the prevalence of blindness and visual impairment has reduced in the past 3 decades from 5.3% to 1.1% thanks to collaboration between everyone. The gender difference between men and women is much, much lesser compared to so many other countries in the world, considering that Nepal is still a least developed country. Cataract is still the commonest cause of blindness and visual impairment due to high UV exposure in the Himalayas, but refractive errors are the commonest cause of mild visual impairment. Retinal causes are on the rise. Glaucoma is next common. Corneal causes are reducing, which is good. That means vitamin A deficiency, trachoma, measles, other corneal conditions are reducing. And surprisingly, Tarai region, which has the most eye care centers, has almost double the prevalence of blindness. This is to acknowledge all the collaborators who went to making this study possible. It was done over 3 years with a sample of 33,000 people. So I thank all of them once more. Thank you.
Thank you, Parikshit. So, Dr. Prashant, you take the question.
What will be your explanation for reduction? And do you think there are some confounders which could have, because 5-fold reduction or almost 4-fold reduction is a very significant reduction in 30 years?
So one of the reasons is in the last century, Nepal was really inaccessible and very, very less developed. So its prevalence of blindness was much, much higher than India. That is one. So the base that we are saying is, it's a very weak base on which it is built on. That's one. It's done by the RAB methodology. That's an internationally standardized method. It has been done in more than 70 countries in the world. So statistically, the methodology is very, very strong. We cannot doubt that. It is stratified random sampling. It goes down to almost 1,000 individuals in a population. So that is one. Second is Nepal's success story is hugely because of collaboration. The other thing is almost 85% of the surgeries are done in the NGO sector. And international agencies, European, American, and even Indian agencies, Arvind, LV, they have helped so much. So that is another reason. And third is, in spite of all the chaos and the political uncertainty that has happened in Nepal in the last 30 years, eye care sector and eye care delivery has gone from strength to strength, as this survey shows.
Thank you.
Thank you, sir.
Thank you. The next presenter is Dr. Purna Chandra
I don't have presentation.
on variation in gene genetics and possible repair, Indian community perspective.
So, good afternoon, everyone. As we all know, in the last 15 years, we have discovered more than 500 disease-causing genes in the eye, and bulk of it is from the inherited retinal dystrophies. And this is the conversation which happens once we diagnose the inherited retinal dystrophy. You have a retinal dystrophy. How do we cure this? Sorry, no cure. Can you do something to treat? Nothing can be done. You can use low vision aids. You can go for visual rehabilitation. So, can this condition pass on to next generation? You can go for genetic testing. Then patient comes up with a series of questions like, does my vision going to go deteriorate? Will I go blind? Can I do something to stop the vision loss? Can there be something in the future to treat? To answer some of these questions, this needs to be studied in the Indian context. So this was the roadmap for our study, to identify the families with inherited retinal dystrophies, identify and isolate the mutation, studying these mutations in cell lines, how to repair this mutation, and also to study the effect of this repair. This was an observation study approved by Institutional Review Board, where all the patients underwent comprehensive evaluation, including imaging, and electrophysiological tests were done wherever it was required. And for genetic testing, we used next generation genetic sequencing using 240 retina-specific genes to look for the variations. Among 5,108 patients of IRDs, 524 patients underwent genetic testing. In that predominant mutation, what we found was ABCA4. We also detected other mutations also which were reported in the literature, but the predominant one was ABCA4, known to cause Stargardts. Coming back to my title, how this data helps to understand the variation, genetics, and possible repair. Let me explain it the case example. This was a 43-year-old female who had a macular atrophy. When he did a genetic testing, we ended up discovering totally new gene called SERPINF1. Incidentally, symptomatic father and asymptomatic children were also carrying the same gene. When we examined the father also had macular atrophy. Children who were asymptomatic, where fundus looked normal, OCT was near normal. When he did an autofluorescence, there was an abnormality in the macular region. So this is the autofluorescence and corresponding OCT across 3 generations with increasing severity. How to stop this? I'll come to it in the therapy aspect. So this was one more interesting family where the proband was a 14-year-old female, had a foveal atrophy. When he did a genetic testing, she had a compound heterozygous mutation in ABCA4 gene. Mother, who was asymptomatic with 6/6 vision, was homozygous for one of these mutation. However, when he did an autofluorescence, there were subtle changes in the perifoveolar region. This is the typical example for same gene, same disease, same family, but depending on the mutation, severity could be different, which is more so common in the Indian community. And to study the effect of these mutations, we used human embryonic kidney cell lines. To make this simple to understand for the clinician, the darker that band, the better is the protein function. If you go and look at the corresponding patient, this was a 13-year-old male who had a V type of mutation with a better protein function, had a milder disease, as compared to the second patient who is 9 years, that means 4 years younger to the first patient, has Q type of mutation with very poor protein function, has severe early onset macular atrophy. The ERG was also telling the same story. In the first patient, it was almost near normal fulfilled ERG. In the second patient had severe rod cone dysfunction. Coming to the repair aspect, gene therapy can offer some help, but there are some challenges when it comes to clinical grade vectors for gene therapy. That's the reason already approved gene therapy product costs in crores, which most of the Indians cannot afford. So how to bring down the cost? This needs to be produced here indigenously, which is a little complex process which involves transfection, harvest, and it has to undergo multiple purification process. Even if you end up doing that, there are some challenges because the commonly discovered genes which I told in our study, ABCA4 and USH2, are the very large genes which cannot be loaded into the single virions. For that, we came up with a novel dual vector strategy where we split the gene into 2 of. They were loaded into the separate virions. Once they are co-infected together, they reach the target cell where they are expected to function normally. All these vectors were produced here itself in our lab, which is first in India. And we used the Stargardt's ABCA4 knockout mice to study the effect of these vectors. So this is the wild type with a normal functioning ABCA4. This is the mice which had ABCA4 gene was knocked out. You can see increased autofluorescence. When we injected our dual vector, as compared to the treatment naive and the control mice, the mice which received our dual vector, there was a significant decrease in the autofluorescence. We went one step ahead and we did ERG in these animals. As compared to the control and the non-injected control, there was improvement in both outer and inner retinal function, thereby indicating there is not only a structural improvement, but also it translated to a functional improvement. To conclude, I would like to say what was known was, we used to diagnose dystrophy, that's where the story used to end for the patient. What this study adds is genetic sequencing and screening data from Indian families. new genetic and phenotypic variations were studied, and we also studied pathogenicity of mutations, and animal models for dual vector study was also conducted. The future plan is to start the human gene therapy trial. I have shown Stargardt's as an example with ABCA4. Since we have our own sequencing vector production facility, it can be done for any gene which you all come across. Thank you so much.
The question is, as a clinician,
Yes.
so what is your role in this whole study?
Yes, sir. My role. Sir, thank you, sir. My role is, as I told, the first thing is to understand the severity of disease. If I take one example where I showed the two children's 9-year-old and the 14-year-old, the 14-year-old had a milder disease with a better protein function, I will not disturb them, because gene therapy is not a simple process where you have to do vitrectomy, do subretinal injection. Whereas the second patient with the 9-year-old, we had a severe macular atrophy, I will select him for the gene therapy in the future. And also it is giving me an opportunity to counsel them. Because once we diagnose this and when we tell there is no treatment, next question patient asks is what's going to happen in the future. Now I know who is going to have a severe course and who is going to have a milder course. The way they plan their career, what they do, everything depends on what we choose. And also therapy, at the 9-year-old, I'll be a little aggressive, I'll do whatever it takes to prevent that, whereas the other patient I'll observe.
Thank you. So, next, Rashmi Deshmukh. So, that side is not working, that side of the podium. AV people, please check.
Working.
Working. So, please, you start from here. So, next person is Dr. Aditi. Aditi Anil Kumar. You just go there so we can save time. Yes, you start.
Thank you. At the outset, I would like to thank AIOS for the opportunity to present our work. So we all know that keratoconus is a bilateral and often asymmetric disease, but progression is not always seen in both eyes, and there are certain eyes which remain stable, and there are certain eyes which continue to progress. Even in the same individual with bilateral keratoconus, we can sometimes have one eye which remains stable while the other eye keeps progressing. But we don't know the reason of this, and so we wanted to ask the question, why do some eyes progress while others remain stable? So the objective of this study was to analyze the biomicroscopic changes in progressive keratoconus and correlate with biomarker changes to understand pathophysiology of progressive disease better. So we included patients who were more than 18 years of age with bilateral keratoconus but had only unilateral progression on follow-up visits. And we excluded all patients who had previous ocular surgeries, allergic conjunctivitis or VKC, patients on topical medications, contact lens users, or patients with hormonal disorders or any kind of hormonal medications. The sample size was calculated and was found to be 15 in each group. Both eyes of the same individual made sure that risk factors were similar in the stable eyes and the progressive eyes. So we included 20 patients, which meant there were 20 stable eyes and 20 progressive eyes. All patients underwent slit lamp evaluation and corneal topography to establish the diagnosis of keratoconus, confocal microscopy to look at the biomicroscopic changes, and tear sample collection to look at the biomarker changes that were happening in these surfaces. All these tests were done at baseline as well as all the follow-up visits. Confocal microscopy image was analyzed using automated CC-metric software, which analyzes the image as such. It looks at the nerve branches, main nerve fibers, and the branching points, and then it gives the nerve parameters which are directly calculated. For tear sample analysis, we use the Schirmer strip method. So Schirmer strips were used to collect the tear sample, which was placed in Eppendorf tube and stored at -80 degrees Celsius until the follow-up visits when we could see which eye was stable and which eye was progressing. These further underwent BCA analysis and then ELISA testing to look at the biomarker changes. So looking at the confocal results, at the baseline itself, we could see that there was a difference between the stable eyes and the progressive eyes in corneal nerve fiber density, corneal nerve branch density, the nerve fiber length, and the total branch density. These were the representative images of stable eyes and progressive eyes. We also looked at the keratocyte density, but we did not find any significant difference in the anterior stromal, mid-stromal, or posterior stromal keratocyte densities. Looking at the follow-up visits, in the stable eyes, there was no statistical difference in the first visit and the follow-up visit in the nerve parameters. But in the progressive eyes, we saw that the nerve fiber density, nerve fiber length, and total branch density continued to reduce, and this was statistically significant. So we further went ahead and performed a correlation analysis of these structural changes in the nerve parameters with tear biomarkers which were already known. And we found that there was a strong correlation between the subbasal nerve plexus features and interleukin 2, 21, and CCL2. Looking further, the interleukin 2 and interleukin 21 showed significant correlation with corneal total branch density in progressive eyes, and it was not significant in stable eyes. And looking at CCL2, which is chemokine ligand 2, again a significant correlation was seen with nerve fiber density, total branch density, and nerve fiber length, which was not seen in stable eyes again. So we could conclude that there was a significant difference in the nerve parameters and the tear cytokines in progressive eyes as compared to stable eyes of the same individual. So looking through literature, we already know that confocal biomicroscopic changes in the corneal nerve morphology are already known in keratoconus as compared to normal eyes. And inflammatory biomarker profile has also been studied, and inflammatory cytokines are increased in keratoconus as compared to controls. In this particular study, though, we were able to look at the confocal analysis for biomicroscopic changes in stable eyes versus progressive eyes and correlate them with biomarker changes and come up with specific biomarkers in progressive eyes as compared to the stable ones. So to conclude, what we already know is that keratoconus is a bilateral and asymmetric disease, but not all eyes progress at the same rate. And confocal microscopic changes in nerves and keratocytes are seen in keratoconus as compared to normal eyes. What this study adds is that there is a significant difference in the corneal nerve parameters in stable versus progressive eyes in keratoconus. We did not find a difference in the keratocyte features. Interleukin 2, 21, and CCL2 may have a role to play in these structural changes and could be targeted to arrest progressive disease. Thank you.
Thank you, Dr. Reshmi. Confocal microscopy is a good instrument to see all structures of the cornea.
Yes, sir.
Was there any effort in your part to look at the epithelium, because that makes sense, because that's going to be bathed by your tear film, and you know that there are epithelial changes,
Yes.
especially thinning,
Yes.
and that is now being a big factor at all. Did you look at it? Why did you look only at the nerve factor?
So we looked at the nerve changes and the keratocyte density because in literature we already know that they have a role to play in ectasia as such as compared to normals. But then within ectasia, when we see that some eyes remain stable and the others keep progressing, we were trying to look at whether these factors are important there. We by default had excluded all patients who had any kind of ocular surface disorders, and during our study we did not see any patients who had any epithelial activation at least, but we have not done any epithelial count or epithelial thickness in confocal as such.
Thank you.
Thank you.
Banana next.
Next, Dr. Aditi Anil Kumar.
My paper is on impact of consanguinity in prevalence, severity, and socioeconomic burden in retinal dystrophies. Consanguinity is a union between couples with a common ancestor. Consanguinity is not an uncommon practice in India, and the prevalence rate is about 9.9% in India. Why is it socially favored? It enforces couple stability. There could be some hidden uncertainties of health and financial issues, and it also strengthens family ties. Most retinal dystrophies are autosomal recessive, and consanguinity goes on to increase the disease burden. So this study looks at its prevalence, severity, and socioeconomic burden. So it's a retrospective observational study of about 5,108 patients between January 2016 and January 2025. Also, a short survey was done with a questionnaire with 40 patients to understand the socio-economic burden of the disease. A comprehensive ophthalmic eye examination was done, including pedigree charting, which was hand-drawn based on recall. They underwent relevant investigations, electrophysiological studies, and genetic counseling and genetic testing wherever possible. So data retrieval and processing was done using Excel. Looking at gender demographics, 39% were females, 61% of males. These were out of the 5108 IRD patients that were studied. The mean age was 31.59 years. These were the dystrophies that we encountered. So if you look at, there is about 75% of consanguineous marriages in a family out of all the dystrophies that we saw. And about 20% at least had 2 consanguineous marriages in the family. Mostly was second degree consanguinity. Depending on the generations involved with consanguineous marriage, about 81% had one generation, 17 had at least two, and about 2% had 3 generations of consanguinity. Individually, 47% in Stargards, in RP, 43% in Stargards, 25% in Conroad, 58% in Conroad, 60% in Rodcone. LCA showed 69%, macular dystrophy 25%, and rest in unspecified hereditary dystrophies, they were about 66%. And about 10.2% of individuals who already were affected still went on to marry consanguineously, and about 0.3% of patients with 3 affected members went on to still marry consanguineously. This is a case of a 23-year-old newly married female, and she is already a known case of retinitis pigmentosa. The vision is 6/9 and 6 in both the eyes, and she came for family planning. She was interested in family planning, so she came to us. So this is the clinical image, shows a classical RP picture. The OCT of the right and left eye, which shows parafoveal loss of photoreceptors. This is her pedigree, wherein she's born out of a consanguineous marriage and also went on to marry consanguineously. She underwent genetic testing, and she was found to have a defective gene. Also, the brother and husband were tested. The brother had the same defect in a homozygous state, and the husband had heterozygous state. So she was counseled for the same. The short questionnaire looked at impact of mental health, financial issue, and negative aspects of social life. About 55% told that they had an impact of mental health. About 72% said they have financial issues due to the existing medical condition, and a whopping 90% said it affects them or their social life negatively. So in spite of telling them about the condition and how potentially blinding this could be, only 10% underwent genetic counseling. So there is a preference for consanguineous marriages primarily based on deep-rooted social and cultural factors. It's a huge emotional and psychological burden. So this study shows us a South Indian data on the impact of consanguinity on retinal dystrophies. There's a huge lack of awareness about genetic counseling, inheritance pattern of dystrophies in the community. These are my recommendations. Thank you.
So, I think this for the panel, this comes under the section diabetic retinopathy and medical retina. Anyway, that is not the fault of the presenter. Do you, the 10% is really concerning, the percentage. Do you think that people were aware of it but did not want to do it, or was it just a lack of awareness completely?
So there are two groups of people. Some are aware and some know about it but still don't want to go ahead with the counseling because they are still, like I said, it's such deep-rooted socially and because of the cultural factors also. They are aware of the potentially blinding diseases. They've seen other family members also. But I guess there is a huge gap to reach there where they actually avail counseling and then genetic testing to understand the disease burden and therefore take a wise decision.
Yeah, because it is tricky in an Indian situation where the family decides, not the patient, whether the patient goes for a counseling or not. So that is one thing which we have found out, and I'm sure you would be doing follow-up studies on this. But this is a good start, at least to know what has been done.
Just one add question that, do you see the religion-wise, just for, because of demography it is required,
Yeah,
what
I
is the
understand.
religious?
Thank you, sir. But the religious aspect in terms of consanguinity was not established in our study. But it would be interesting to look at it to understand how it spreads out in that aspect, yes.
Next presenter, thank you, Dr. Obaidur Rahman.
Dr. Obaidur Rahman, please. And next to Obaidur Rahman is Dr. Manik Sardana. Please on the side, other side.
Okay, good afternoon, everyone. So I'll be talking about auricular cartilage grafting for cicatricial entropion in ocular surface disorders. So we know that chronic ocular surface disorder leads to a host of ocular surface and eyelid deformities, including keratinization of the margin, tarsoconjunctival scarring, and eventually cicatricial entropion. But the posterior eyelid margin plays a very important role in maintaining the overall health of the ocular surface. But severe cicatrizing processes lead to lamellar shortening and loss of tarsal integrity. These chronic changes may be seen in up to 90% of SJS patients. There are already established procedures like eyelid margin MMG, which is done in SJS patient, but it gets negated when there is cicatricial entropion because there is still constant rubbing of the eyelid margin. And we know that any ocular surface that these ocular surface surgery that these patients might require will require a stable surface. So single stage entropion surgery with MMG has already been described, but when there is severe posterior lamellar shortening and loss of integrity of the tarsal plate, such patients are not amenable to these conventional procedures. So through this study, we want to describe the clinical profile, surgical technique, and outcomes in auricular cartilage grafting for these patients. So we conducted a retrospective analysis of the EMR record where the primary outcome was restoration of eyelid position and the secondary outcome was ocular surface staining score improvement. So this is a short video demonstrating the surgical process where the eyelid margin keratinization is being excised here. After excision of this keratinized margin, there's a full thickness tarsotomy done and 2 tarsal plate segments are created. This defect is created till entropion gets corrected. Now the posterior auricular surface is infiltrated and an incision is created up to the cartilage. Here the cartilage is harvested according to the defect. And then the incision site is closed. This cartilage graft is placed in the defect created and then secured with 6 vicryl absorbable sutures, as seen in this video. And eventually, a small strip of mucous membrane is placed at the eyelid margin and secured there. This leads to correction of the entropion, which is followed by placement of a bandage contact lens. So in cicatricial entropion, when there is constant rubbing and deterioration of the ocular surface, when this cartilage grafted is harvested from the air, what it leads to is lengthening of the posterior lamella and movement of the eyelid margin away from the globe, leading to improvement in the ocular surface. So we enrolled 16 eyes without any sex predilection, and the lower eyelid was involved more because it is less robust than the upper eyelid. The most common etiology we noted was SJS, and 5 patients had simultaneously MMG. We followed up these patients up to a mean follow-up of 16 months period. The primary outcome of entropion correction was achieved in 15 eyelids, and the secondary outcome of ocular surface staining improvement was achieved in 10 eyelids. 81% of our patients subjectively reported improvement in watering and photophobia after the procedure, and 5 of these patients could subsequently undergo successful cataract surgery or keratoplasty and are still on follow-up. This is one of our patients, and you can see post-procedure improvement in the ocular surface and photophobia of the patient. 1 eyelid required further correction with everting sutures, and 2 patients had cosmetic blemish, which can be seen on the screen. 1 had a lumpy, bumpy appearance because of the cartilage, and 1 had a very flat contour. But we did not note any entropion recurrence or mucosal ischemia or any corneal epitheliopathy. So when compared to different cartilage materials that are available, cartilage graft is easy to harvest, has a rigidity which matches the tarsal plate without any donor site morbidity. The only drawback is it does not have a mucosal covering as seen in other grafts. But the good thing is that the cartilage graft undergoes complete epithelialization within 2 to 4 weeks. So in conclusion, auricular cartilage grafting in our study was a viable option in severe cicatricial entropion and led to improvement of the overall ocular surface. It corrected the deformity as well as led to improvement of ocular surface, leading to successful ocular surgeries in the future. And there was satisfactory functional and cosmetic outcomes in the long term without any complications. Thank you.
At what time point you made a decision that this patient is cured and there is no recurrence? Because we didn't get idea about what is the follow-up.
So sir,
of
the
these
mean
patients.
follow-up ranged from few months to years. The range of the follow-up was from months to years, but the mean follow-up was 16 months. So
Yeah.
from 2019 to 2023 period, we did not note any recurrence.
Yeah, the mean does not give you the true idea, because the patients who had, say, 3 months of follow-up, is that the right point at which you should have made the decision that this is successful? Or
Yeah, so that's one small drawback of the study, that there was no defined minimum follow-up. But when this was compiled in 2024, we took retrospectively our patients from 19 to 23.
No,
but there was no minimum follow-up period.
How
Yeah,
many
that's
were
the drawback.
lost to follow-up?
2 patients were lost to follow-up, again not included. Thank you.
So next speaker, Dr. Rabi. No, Dr. Manik. Yes, yes.
So good afternoon, everyone. The title of our study was Characterization of Peters Anomaly with Glaucoma, Clinical and UBM Perspectives. There are no financial disclosures. Coming to the background, Peters anomaly is characterized by a central corneal opacity, defect in the descent membrane, shallow anterior chamber, and synechiae between iris and cornea. It has been classically subdivided into type 1, type 2, and Peters plus, and these are the known genes that we know of as of yet. So UBM is a high frequency ultrasound that visualizes anterior segment in these opaque corneas, and a definitive diagnosis of posterior descent defect is possible with the UBM. Studies have found high degree of consistency between UBM images and histological diagnosis in congenital corneal opacities. So our research question was, what is the clinical profile of Peters anomaly, and is there a prognostic value of UBM characteristics at presentation? Our aims were to describe the clinical profile of patients with Peters anomaly presenting over a 5-year period, to characterize and classify the various UBM findings in Peters anomaly, to correlate the surgical outcome of patients with 1-year follow-up with the UBM findings at baseline, and to study the genetic profile in these patients. Our study was a retrospective cohort study over a 5-year period, which was done after ethical approval. Our inclusion criteria were children less than 5 years of age with childhood glaucoma, who had a congenital corneal opacity with a central clear area, presence of a descent defect on UBM, and which the UBM was done using an open shell technique under general anesthesia, and the following data was collected: clinical characteristics, UBM pattern, genotype, and surgical outcome at 1 year. So our outcome measures were classification of UBM patterns of Peters anomaly, correlation of clinical characteristics and UBM pattern to the surgical outcome, which was graded as good, fair, and poor depending on the control of glaucoma, and assessment of genotype and its correlation to the phenotype. Coming to the results, so over a period of 5 years, we had 32 eyes of 21 children of Peters anomaly with glaucoma, with the mean age being 1.3 months, and the mean follow-up duration was 33 months. The laterality, there were 10 unilateral cases and 11 bilateral cases, and the male to female ratio was almost equal. So over the course of 5 years, we noticed 4 distinct UBM patterns in Peters anomaly. So type A UBM was a descent defect only. Type B UBM was a descent plus posterior stromal defect. Type C UBM was a descent and a stromal defect with iridocorneal adhesions. And type D UBM was a descent stromal defect with corneal lenticular adhesions. When we looked at the numbers, type A UBM was the most common UBM, constituting 47% in our study. Type B was the second most common, constituting 34%, then type C, and we only had 1 eye of type D UBM. Coming to the results, when we looked at the glaucoma outcome at 1 year, 25% of the patients had good outcome and 47% of the patients had fair outcome, with only 28% having poor outcome, contrary to the published results in the literature. We also noticed significant decline in the cornea clarity, IOP, and number of anti-glaucoma medications, along with corneal thickness on UBM, which decreased significantly at 1 year after surgery. We also did optical iridectomy in the 15 of these eyes, and the eyes with optical iridectomy had a better visual acuity at 1 year compared to eyes without optical iridectomy. When we correlated the type of UBM to the glaucoma outcome, we can see that the type A UBM had the best outcomes, with 13 out of 15 eyes having good to fair outcome, which was followed by type C, and surprisingly type B had the worst outcomes, with almost 50% of the patients having poor outcome. We also did genetic evaluation in 76% of these kids and found out that CYP1B1 was the most common mutation in the North Indian cohort. So to summarize, our study was one-of-a-kind study characterizing Peters anomaly with glaucoma. We classified UBM into 4 different types in Peters anomaly, with type A having the best outcomes and type B having the worst outcomes. 72% of the eyes had good to fair outcome, and there was significant decline in corneal thickness after surgery. Peripheral optical iridectomy offers some visual rehabilitation in these children, and CYP1B1 mutations dominate the North Indian cohort. So to conclude, this study provides novel insights into the UBM characteristics of Peters anomaly and helps in better prognostication of affected patients through UBM-based classification. Thank you.
Thank you, Manik, for a nice presentation. So I have a question, like, you have said that this group you have given 3 glaucoma drugs. We know the drugs in pediatric population is very difficult to choose. What are those 3 drugs or more than 3 drugs?
Sir, usually the first line we give is carbonic anhydrase inhibitors. If the IOP is not controlled, then we combine it with timolol. And the next drugs are very difficult to choose, but even if we need it, then we can go ahead with the PG analogs and the newer generation Rho kinase inhibitors.
No,
can
you have
also
said
be given.
already, more than 3 means you have
Yes.
chosen already.
Yes, yes. So these are the 4 drugs. We always avoid brimonidine in these children, but these drugs can be safely given in children. So we can.
So do you give any special instruction to the parents regarding giving these drops?
Yes, we ask to strictly do punctal occlusion while
Okay, next.
giving these drops.
So next, our speaker is Dr. Ravi. Dr. Ravi Ranjan. He'll be speaking on DCR failed, nothing to worry.
Good evening, everyone. My topic is DCR failed, nothing to worry. No financial disclosure. And the impact of failed surgery on surgeons, often referred to as the second victim, is profound, and they experience significant consequences. As published in various journals, success rate of external DCR is 85 to 98%. And despite excellent success rate, there are large number of cases with failure, typically due to these written causes. To overcome the problem, we conceptualized a small flap saving technique of repeat surgery, which is easy to perform with successful result and a short learning curve. And the aim of this study is to evaluate the success rate of repeat DCR using a small flap saving technique, which is a prospective interventional uncontrolled study with 134 patients from March 2011 to August 2023. And all the surgery was performed by a single surgeon to reduce outcome bias, and the inclusion criteria was Rho plus after 6 months of the primary procedure. We use a Rugage bone terrifying to make osteotomy. Approximately 1 mm to 2 mm of the lacrimal sac was preserved around the common internal opening of the lacrimal sac, maintaining a dish shape with a central punctum that resembles a funnel, and this adaptation was necessary because obtaining sufficient flap for mucosal anastomosis is often challenging in repeat surgeries. As a result, the technically difficult flap creation and suturing of the posterior flap have been omitted in this modified procedure. And the upper portion of the preserved flap was sutured to the subcutaneous tissue or periosteum on the medial side of the skin, and the wound was closed. And on the 5th postoperative day, 1 ml of 0.4 milligram per ml mitomycin C was administered in the newly formed passes, and these all cases were followed up for 1 year. And this is the nasal endoscopy after 1 year, and here we can see osteum, nasal osteum. These all cases were followed up on 5th day, 1 month, 3 months, 6 months, and 1 year post-operatively. And at each visit, the surgical outcome was assessed anatomically and functionally based on the record from the last visit. And the result of the 134 patient operated over 12 years. 12 years is 131 patients were successful at the end of mean follow-up period, that is 12 months, and 2 patients complain of epiphora of grade 2 or more despite successful syringing, and 1 patient failed in syringing. And now we come to the statistical analysis. For the comparison of this study with the previously published studies, meta-analysis were performed using MedCalc software, and the Cochrane chi-square test and inconsistency were used to assess the heterogeneity among studies, and p-value less than 0.05 was considered to indicate the presence of heterogeneity, while inconsistency more than 50% was considered to indicate acceptable heterogeneity, and the proportion were reported with 95% confidence interval. And this is table 1 comparison of the success rate with the published studies, and this is the meta-analysis of the success rate reported in identified studies on FALDCRs. And this is the forest plot. This is the forest plot depict that the a study by Wu et al. Can be the source of heterogeneity. And the symmetrical funnel plot suggests the absence of bias. And the meta-analysis of success rate showed significant heterogeneity, that's it, equal to 87.48%, 95% CI, lower bound 76.52 to upper bound 93.33%. And the Cochrane Q is 47.9 and p-value is less than 0.0001% between the reported studies. And the now question is why mitomycin C syringing on the 5th post-operative day. We use 1 ml of 0.4 milligram mitomycin C syringing on the 5th post-operative day so that the antifibrotic property of the mitomycin C is utilized maximally, as it is not diluted by bleeding from the nasal mucosa and better coincides to the early proliferative phase of wound healing, which will start from 4 to 5 days of tissue injury. And thus we can our anatomical success is 133, functional is 131, and the success rate of this study is significantly better than the previously published report despite large sample size. That's we can say. DCR failed, nothing to worry.
Thank you, Dr. Ravi.
Thank you.
So,
Thank you, Prof.
Ganesh, you will take up the question. Our next speaker is Dr.
You looked
Farnaz.
at the success by doing Groplas, but is that enough? Why was syringing not done for these patients?
On 5th post-operative day, I am syringing.
But the blockage can occur even later on. So is Groplas good enough to conclude that?
I am already following up for 1 year, and during endoscopy, I have got that if 3 to 4 months, after 3 to 4 months, if it is patent, it remains patent for year and onward. Because in first case, now it is 12 years, and it is still patent.
Thank you.
Okay. Yes, Dr. Farnaz.
Hi, hello, and a very good afternoon. Optic nerve glioma and optic nerve sheath meningioma. So are these tumors a clinico-radiological diagnosis? If so, why is it a diagnostic difficulty? Let's find out. Optic nerve gliomas comprise 1% of all the intracranial tumors, whereas meningiomas 1% of all meningiomas. However, optic nerve glioma is the most common optic nerve tumor, whereas meningiomas being the second most common. Why is it considered as the diagnostic difficulty? First reason being the rarity of the disease, and the second being commonly misdiagnosed as optic neuritis and thereby leading to all the problems as listed on your screen. Ours was a retrospective study where we analyzed 36 optic nerve tumors, 15 gliomas and 21 meningiomas for the following. The mean age was 15 years among the glioma patients with 53% males and 43 years in the meningioma group with 57% being females. The main clinical features were protrusion of the eye, diminution of vision, strabismus, extraocular movement restriction, and disc changes. However, normal disc was seen in 13%, followed by mild pallor, severe disc pallor, hyperemia, choroidal folds, and optociliary shunts. The mean duration of symptoms among the glioma patients was 52 months and 73 months among the meningioma patients, with most of them having protrusion and diminution of vision. The appropriate imaging for optic nerve tumors is MRI brain with orbits, plane, and contrast. On your left side, on your right side, glioma demonstrated by the enlargement of the nerve itself, hypo-intense on T1 weighted images. However, a soft tissue mass along the nerve sheath on the other side, hypo-intense on T1, is suggestive of meningioma. In T2 weighted images, glioma displays high signal intensity and is definitely hyperintense, whereas meningioma is either iso to hypo-intense. Contrast enhancement is seen in both the optic nerve tumors, gliomas usually irregular and botchy, whereas meningiomas regular circumferential enhancement with a centrally non-enhancing optic nerve. The two classic radiological signs of meningiomas are the tram track sign in post-contrast axial cuts and the donut sign in coronal cuts. The patterns of meningioma enlargement could be tubular, which is the most common, globular with an exophytic expansion, and fusiform with elliptical and tapered ends, and this getting commonly confused with glioma. Type 2 being extension to the optic canal and supraorbital fissure, type 3 being intracranial extension. The treatment strategies for gliomas in our series was chemotherapy in 7% of the patients, usually under 3 years age group, Until the child gets fit for radiation therapy, 67% received radiation. Among the meningioma patients, the widely used treatment strategy was radiation therapy, done in almost 95% of patients. Incisional biopsy and debulking was required only in few ambiguous cases, especially when there is disfiguring proptosis. EBRT in such cases, T1 weighted axial and coronal images with gadolinium contrast is registered with the planning CT. The gross tumor volume is defined as the area of contrast enhancement, and this, when expanded by 1 centimeter in all the directions, gives the planning target volume. Target specific gradient of radiation therapy, the area of the tumor, which is the area of interest, as in the first image, receives 95% of the prescribed dose of radiation, followed by the surrounding area receiving 50% and the further surrounding area receiving 20% prescribed dose of radiation, thereby preventing collateral damage. Let's have a look at the patients who did very well with improvement in the strabismus, improvement in the visual acuity, and also reduction in the size of the tumor. Here is an example of glioma. Followed by meningioma patients who had resolution of proptosis, improvement of vision, and also the reduction in size of the tumor. So our study stands out in the way that 100% MRI and correlation was done, and following EBRT, they had excellent visual outcome. So yes, glioma and meningiomas can be diagnosed clinico-radiologically, thereby restricting surgical intervention only to cases of disfiguring proptosis and intracranial extension, early diagnosis, fundus examination, requesting the correct MRI, precision of reporting, earlier access to neuro-ophthalmologist and ocular oncologist, etiology-based treatment with neuroprotective EBRT leads to better visual outcome and stability. Thanks a lot.
What's new in your findings? This is the known things. What's new?
Yes, sir. Three things. The first thing is usually it's a diagnostic difficulty that gets commonly confused with optic neuritis, thereby leading to inappropriate steroid treatments. So with this, we will be able to triage the patients accordingly if it is glioma, chemotherapy or radiation, and meningioma towards radiation, along with neuroprotection, thereby there is no harm to the optic nerve as well.
I have the same concern and question, because your topic, your title says clinico-radiological diagnosis and a question mark.
Yes.
So I would have expected that you would have correlated the clinical versus radiological, but this was mostly on the treatment part as well?
Yes, sir. Together, clinical, radiological, and the treatment part, especially the etiology-based.
Okay, thank you.
Thank you, sir.
Dr. Neeraj Kumar Shaw. Yes.
Good afternoon. So in my study, I'll be presenting about the longitudinal
Showed
data.
up October the next.
I'll be presenting the longitudinal data in choroidal osteoma, which gave us some clues regarding the deossification dynamics and the natural history of choroidal osteoma. As we all know, it's a benign ossifying tumor, and increase in size and decalcification is a known entity. Most of the studies on choroidal osteoma, the longitudinal studies and predictive factors, mostly done by the Shields group, and it was done in the pre-OCT era. And subsequent multimodal imaging papers, some classifications like deossification has not been defined properly. So thus we aim to analyze the multimodal imaging findings and longitudinal changes in choroidal osteoma using multimodal imaging. This was a retrospective longitudinal observational study of all cases with choroidal osteoma from 2012 to 2024. Clinical data and imaging features were taken. And this is the first definition that we did, the deossification choroidal atrophy. Because deossification is a continuous process, we took the final outcome, that is the atrophy, into the classification, and it was defined as the absence of osteoma lesion with visible choroidal vessels and thinning of choroid. The next definition was RP atrophy, which was defined as yellowish-white discoloration, as you can see here, which along with hypoautofluorescence on FAF and transmission defect on OCT. As you can see here, there is no deossification below it. From 14,000 files, we took almost 100 eyes of 80 patients, making it almost the largest size, largest subset of choroidal osteoma ever reported. Most of the cases were unilateral and females with no systemic associations. This is an example of an uncomplicated choroidal You can see there is no RP atrophy or deossification or CNVM. It looks slightly mildly hyperautofluorescent on autofluorescence imaging. And when we analyzed the number of cases with atrophy, we found it was around 38%, and RP atrophy was present in 82% of cases. Now, initially, we thought that there was some age-related factor that was causing it. As you can see here, RP atrophy was seen in a decade earlier than deossification process. But when we did a multivariate regression analysis, we found that the total area at which it presented, that was the only thing that was significant on multivariate regression, which was causing the deossification and RP atrophy. Coming to the longitudinal changes, we could see that the total size of the osteoma lesion, the average ossified area and deossified area, all three were increasing. Now, something was odd here. Increase in one should have been accompanied by decrease in another. And it was seen because of something like this. There was, as you can see here, after follow-up of 6 years, deossification increased in one of the poles, while the osteoma was also growing in another pole. Another characteristic we evaluated was these hyperphotic cavitations. As you can see here, when these cavitations appeared, it was accompanied by a reduction in the osteoma thickness. We also analyzed the increase in osteoma thickness. When these osteoma thickness increased, there was a statistical significant association with an SRA formation without CNVM development. So based on these findings, we came up to 3 clinical types of choroidal osteoma. The first is osteoma without RP atrophy or deossification. Second is osteoma with underlying RP atrophy but without deossification. The third is RP atrophy with deossification. Now, if you see these, the third one, you can see that all 3 zones can be clearly seen. The osteoma without the overlying RP atrophy, osteoma with overlying RP atrophy, and the deossified area. And this can be confirmed using OCT. So just to conclude, deossification process and the osteoma growth may coexist. The higher total area at baseline predisposed to faster deossification, and an increase in osteoma thickness is associated with SRF development without CNVM, possibly due to alteration in the choroidal dynamics. Thank you.
You know that first thing we do in osteoma, when you suspect, you do an ultrasound. So did you do the ultrasound in all cases?
All cases were confirmed using ultrasound.
Okay. Except the number, a huge number. What is that novel in your finding?
We used multimodal imaging to characterize the OCT findings also. In the previous databases, nowhere it is mentioned about how the OCT or the thickness changes over time and what are the factors affecting it. So including OCT in our data set makes it a large data set, including that takes care of the entire dynamic of the osteoma lesion.
How often is the choroidal neovascularization seen in your osteoma setup?
We saw in almost 40% of eyes. We have not utilized or analyzed it in this paper, but in another study we are publishing it. Almost 40% of eyes had CNVM that required treatment.
You have the chance to see that a lot of osteoma cases. How often the misdiagnosis of osteoma as choroiditis or other entity was made?
It is quite high. So that's why from almost 14,000 cases, we had to manually check whether the diagnosis of osteoma is correct or not, and then include 100 eyes.
Okay. Next, Dr. Saurabh.
Yes. May I start? Good afternoon, everyone. I am Dr. Saurabh Patwardhan from the Nandadip Eye Hospital, and I will be presenting my paper on changes in accommodation facility with varying accommodative demand. There is no conflict of interest. So mechanism of the eye to focus in order to attain maximal retinal image clarity is called accommodation. Ciliary muscles are actively involved in this process and are more prone for spasm as well as exhaustion. Apart from vision-related abnormalities, the visual disorders, including accommodative and binocular vision issues, have significantly higher nowadays in younger adults. As a result of global adoption of digital screens, working distance has considerable change, wherein users must have to quickly adjust their accommodation to focus on visual display unit, then relax their eyes on accommodation at distant things. So the study was aimed to assess variation in the accommodative facility at different accommodative demand distances across refractive errors with fixed target size and testing flipper. So aim is to assess the accommodative facility in patient with emetropia, low myopia, low hyperopia with varying accommodative demand. to assess the variation of accommodative facility at subject working distance and different target distances at 30, 40, and 50 centimeters. So it is a cross-sectional study. It was conducted in 6 months or in 2024 at Nanda Deepa Hospital. The sampling size was sampling was done randomly. 70 subjects from OPD 18 to 26 years of age. So basically young adults. The materials used was well-site rock card of 6x9 and accommodative flipper of plus minus 1.5 diopter. We included young patient 18 to 26 with hyperopia within plus 2 diopters and myopia within 2 diopters and emetropic subjects. We excluded any other patients. After the baseline evaluation, we tested their accommodative facility. So accommodative facility is tested by using the flipper. So the participants have to clear the target at that distance with plus 1.5 and then minus 1.5. And they have to then repeat the cycle. So we check the number of cycles they can clear in a minute. So going to results, we found that there were 56% included in males. Refractive distribution was around equal in 3 groups. When we found, when we checked the cycles that they were clearing at 30 centimeters, 40 and 50 centimeters, we found that amongst emetropia, the cycles were more, that is around 7 plus minus 5, and it reduced to 3 plus minus 1 as the distance increased. The same trend was noted in emetropes. The accommodative facility was slightly more in hyperopic patients, but again, it was not statistically significant. Facility at 30 centimeters was more across all the refractive errors. The average accommodation, so to discuss, the average accommodation amplitudes of non-myopes are significantly higher than those of myopes as per the earlier studies. Meanwhile, in this study, it was found that the accommodative facility is slightly lower in myopes and emetrope compared to hypermetropic subjects, but at all distances, but it was not statistically significant. It is observed that the accommodation facility decreases with increasing fixation distance, which was a new finding. Though the accommodative facility was higher in hyperopes, again, than myopes and emetrope, it was not significant. The binocular accommodative facility was always more than monocular accommodative facility at all distances in all refractive error patients. So this study shows that accommodative facility is not significantly dependent on refractive status, particularly in low hyperopes and myopes. It is observed that accommodative facility decreases with increasing fixation distance. This has never been documented. We couldn't get any reference to it, and its clinical implication can be studied further. Now, just to add to the discussion, accommodative in-facility occurs when the accommodative system is slow in making a change, or when there is a considerable lag between the stimulus to accommodation and accommodative response. Now, if at 50 centimeters the accommodative facility is less, whether that should change anything, that has to be studied. So the further studies can be conducted with the results and with larger sample size, and target size can also be altered with respect to change in distance. Clinical implications with respect to working distance can be studied further. Thank you, sir.
You looked at myopes, emetropes, and hyperopes. Did you look at pupil size? Because that can also influence depth of field and kind of skew the results of accommodation. And myopes typically have a larger pupil than hyperopes or emetropes. So was the pupil measured, and the influence of the pupil on the results of the accommodative facility?
Yes, so pupil particularly was not measured. These were basically young, healthy adults. So we have to do it maybe in the next study phase. The thing which was striking, and they all had similar accommodative facilities across, so there was no difference. The main thing which actually went against our logic, we were expecting that the facility will be lesser for nearer distance at 30 centimeters than slightly when you keep an object at 50 centimeters, which is longer. But we found it opposite, that the facility is in fact lower for distance of intermediate, that is 50 centimeters. So probably the patients may get fatigue if they have to change the distance when they are working with intermediate and distance. When they have to fix. So basically facility is the quickness at which they adapt to that working distance. And there is no normative database to say that whether these are all asymptomatic participants basically. So but if they are put into a practice where they have to keep working distance as 50 centimeters as again 30, if they are getting more fatigued, maybe this is the reason why. Second thing, why I could just hypothesize why this facility is less. One thing is that accommodation response depends on also the stimulus. So more the blur, faster will be the response. That is one. Second, closer the distance, there will be conversions coming into play, and accommodation conversion, as you know, is associated. These are the two physiological factors. But now, because earlier all accommodation facilities are measured at 30, because that was the commonest distance used by people, whether the lower facility as 50 centimeters is causing all the asthenopia in young adults. So that may be the next topic.
Yeah, it is blurring of image that
yes.
Causes the speed of the facility of accommodation. Yes. And if it's at an intermediate distance, then again when you're actually looking at something close, you also have convergence, and you also have size reduction in the pupil size. That's why I was interested to know whether you actually measured pupil size. Yes. That also increases the depth.
Yeah, of course. But of course, I think more than that, I think the conversion. But I think what I want to study further is whether, because of the changing working patterns, whether we have to try something to improve the facility at that distance in our patients who will be coming to us for asthenopia. That's it.
Thank you. Next is Dr. Shruti.
A very good evening to one and all. What do we do if a patient presents to us with severe blepharoptosis with poor levator action, and we want to correct the patient with autogenous tissue with a prolonged defect? Yes, we either go for frontalis sling with fascia lata or a frontalis flap. Now, what is already known? It's already known that post-operatively there should be good symmetry in the eyelid height. There should be good eyelid contour that the patient is happy about, and there should be minimum lag of thalamus. While most existing studies limit their outcome measures to only the eyelid height and lag of thalamus, eyelid contour symmetry with the fellow eye is of paramount importance to the aesthetic appearance of the face. Now, this led us to compare the outcome of frontalis sling with autogenous fascia lata and frontalis flap surgery in blepharoptosis using image J-based objective measurements. This was essentially a retrospective review of 41 patients between the time of 2014 to 2024 done at the L.V. Prasad Eye Institute, Bhubaneswar. We included 17 normal volunteers who were representative of all age and gender with no obvious eye asymmetry or eye surgery. So we had a total of 24 patients who underwent surgery, who were subdivided into Group A, which comprised 10 patients who underwent fascia lata sling, and Group B, who comprised 14 patients who underwent frontalis flap surgery. All measurements were objectively derived using the Image J software. Our primary measured outcome was MRD1, and our secondary measured outcome was lag of thalamus and inter-eye nasal bitemporal ratio. Now, what do I mean by that? A digital protractor was superimposed on the standard photograph of the patient. A horizontal line or x-axis passed through the lateral canthus. The vertical line passed through the superior limbus through the center of the pupil. Now, we got a common central point. From there, tangents were drawn at 15-degree interval in order to intersect the upper lid so that we could objectively measure the upper lid contour. Moving on to the results, demography showed that there was a slight male preponderance. Mean age of the normal volunteers were 23.7 years, our fascia lata group was 17.4 years, and frontalis flap group was 34.7 years. Both the groups showed statistically significant and comparable improvement in the MRD post-surgery. So this was contour symmetry as it was analyzed. Inter-eye nasal ratio and inter-eye temporal ratio was compared. We plotted this onto a map. So the graphical representation here suggests that the blue line stood for the mean of inter-eye nasal ratio, and the black line stood for the mean of the inter-eye temporal ratio. So this was plotted for the normal, the fascia lata group, and the frontalis flap group. It was seen that the mean was almost comparable, though in the surgical patients of both fascia lata and frontalis flap, there was a variation or dispersion. Lag of thalamus was worse in the frontalis flap group, which was again not very consistent with that seen in literature, and revision surgeries was more common in the fascia lata group. So a few authors had previously tried to objectively analyze the eyelid contour with respect to temporal by nasal ratio in conditions like Graves' disease and congenital blepharoptosis, but no authors had head-on-head compared objectively the eyelid contour post-operatively for two most commonly done ptosis surgeries, which is fascia lata and frontalis sling. So these are few of our before and after clinical photographs of frontalis flap patients, which you can see. Though our study was retrospective in design, which had a slightly smaller sample size, and we considered the horizontal corneal diameter to be 11.5 in all our patients. It was one of its kind. Why? Because we objectively measured the eyelid height and contour using ImageJ software, which is online and free. We compared eyelid symmetry with normal volunteers, thereby reducing subjective bias in outcome. And in our study, we saw that frontalis flap gave comparable height and contour to fascia lata. We also saw that lag of thalamus was more in frontalis flap patients. I thank you all for your patient listening.
How many surgeons were involved in this?
So this was done in L.V. Prasad Eye Institute, Bhubaneswar, and it was done by Dr. Surya Natharat.
So one
yeah,
surgeon.
yeah.
And was there a very clear, obviously this has some disadvantages with the study design being retrospective.
Yeah.
And when you compare two techniques, was the indication same?
Indication as in,
For
yeah. So
for both the groups?
yeah, so the post-surgery, because there will be a bit of eyelid edema, we measured it only after 6 weeks post-op.
I agree. The question is not that. When that was there, and when one surgeon was there,
Yeah.
and the indication was just that, how did that surgeon decide that this patient will get this and this patient will get that?
This patient will
get a frontalis sling versus a flap.
Oh yeah, so usually for very small patients, we usually decide that we'll give them a fascia lata correction. But if it is slightly older patient, then we go for frontalis flap surgery.
So that is why I asked you whether the groups were comparable. So you mean to say that there were two different groups of population?
Yes, there were two different patients.
Okay.
Yeah, group of patients.
Dr. Shweta?
And the other thing is, did you look at the head posture pre and post? Because
Yes.
normally there's a change in the head posture, and
Yeah.
that can affect the image for contouring.
Yes. So we have a particular photography room designated for that and a photographer. So whenever we click standard and high profile photos, we make
Because
sure
usually
that
with,
the head.
with ptosis, they have like a chin elevation, and after the ptosis surgery,
Yeah,
it comes
yeah.
down, and that can, so if you don't maintain the same head posture
Yeah.
pre and post, that can change the
Yeah.
contour.
So we have an official photographer and a photography room, and that is taken care
But
of.
what was the technique to ensure that the head position was the
Usually
same
we-
pre and post?
So
That's my question.
we give a common point for the patient to look at, and
Head posture.
yeah.
How did you measure that? Oh.
Okay.
Good afternoon, everybody. There are no financial disclosures. So CFUM is a rare congenital cranial disinnervation disorder which is caused by the maldevelopment of third and fourth cranial lobes. CFUM phenotype is one is caused by KIF21A mutation and CFUM3 is caused by TUP3 mutation. So in this study, we aim to prospectively investigate the clinical, genetic, and imaging characteristics of Indian CFUM cohort and also perform a phenotypic and genotypic correlation. So it was a prospective design study done in PGI Chandigarh between October 2018 to 2024. CFUM patients with or without ptosis with minimum follow-up of 6 months post-operatively were included. Both ophthalmological and detailed ocular motility examination was done along with the MRI, CIS sequences for the cranial nerves and dedicated thin quasi-coronal MRI orbit for the muscles. Dynamic orbit was done in selective cooperative patients. Whole exome sequencing was done using the NovaQ platform. To coming to the results and discussion, there were total 18 patients were identified. There were 6 pedigrees and 6 sporadic cases. Average age was 15 years. All showed autosomal dominant inheritance with heterozygosity. Anterior and fundus examinations were normal. There were 15 CFM1 phenotypes with both itosis and upgaze palsy. The globes were infraducted and chin-up posture was there. There was perverted convergence in upgaze and divergence in downgaze. And there were 3 CFM3 phenotypes with either asymmetrical or restrictive strabismus or brain malformation. Coming to the imaging, the third nerves were hypoplastic in all the patients and 6 nerves were affected in 2 patients with CFM1 phenotype. Parenchymal atrophy was present in 1 patient and corpus callosum abnormality was present in 2 patients. The medial rectus and superior rectus was thin in all the patients, and you could see that the cross-sectional area of the muscles, medial rectus and superior rectus, was much thinner than the normal population. Compared to the lateral rectus, medial rectus and superior rectus was thinner by 25%. So there were 5 adult patients who underwent dynamic orbit. Synergistic convergence was present. Synergistic convergence and divergence was present in 3 adult patients, and synergistic innervational downshoot was seen in 2 patients. Coming to the genetic, there were 9 patients who had KIF21A mutation with 2 pedigree and 9 patients with TUP3 mutation with 4 pedigree. And KIF21A results in defective kinesin protein and TUP3 results in defective microtubulin protein. And this kinesin dimer attaches and moves along the microtubules, and it is critical for the human nervous system development. So among the 15 phenotypes, we had 60% of KIF21A and 40% of TUP3, where the literature says that they are predominantly KIF21A. And the 3 phenotype, we had all TUP3 mutation. This is maybe because of the phenotypic overlap between the TUP3 and KIF21A mutation, which suggests a shared disease mechanism underlying the 2 disorders. This is the exhaustive table. So there were 6 single nucleotide variants, and there were 3 copy number variants. And this C2821 was the most common and novel mutation, as it didn't match with the existing literature. This mutation had 4 patients with marked aberrant regeneration. And also in the KIF21A deletion, the heavier the deletion, more severe was the aberrant regeneration. And in the duplication, we found that only synergistic innervational downshoot was there without involvement of the vertical muscle. This is the C2821 mutation. You could see synergistic convergence in upgaze and divergence in downgaze. And he had thinning of splenium, and third nerves and sixth nerves were hypoplastic. Superior rectus and medial rectus were thinner, and there was a Y-shaped accessory muscle at the back of the orbit. This is a C2860 mutation, and you could see there is a synergistic divergence and innervational downshoot in the right gaze, and the third nerve and sixth nerve were hypoplastic, and the medial rectus were thinner on the left side. Coming to the TUB mutation, there were 2 copy number variant, and there were 7 single nucleotide variant, and this 904 had short corpus callosum. So this is the C211. This is a dynamic orbit. You could see in the right gaze and the left gaze, the yoke muscles are contracting, but you could also see that inferior rectus is in the left gaze, the inferior rectus is becoming much thicker, thereby implying the synergistic innervational downshoot. So coming to the managements, bilateral supramaximal recession was done in 10 patients. Periosteal fixation was done in 2 patients. Bilateral superior oblique weakening was done in 4 patients, and IR to MR transposition was done in 2 patients. These are some of the photographs of the patients showing correction in the primary position hypotropia and as well as the exotropia. So this is the synergistic innervational downshoot, which we have published prior, and you could see simply by the inferior rectus to MR transposition, the patient has got the ortho position. So to take away points are that KIF21 and TUB3 both constitute the CFEM1 phenotype, and C2821 was the most common and novel mutation in our cohort. Third nerves were universally hypoplastic, but 6 nerves could be involved, especially in the 2821 mutation. And MRI imaging is crucial in identifying the structural abnormalities in CFUM. Strength of the study was the correlation between the phenotype and genotype. Still, though we had 18 patients, but still it was a smaller cohort, and advanced imaging and further genetic investigations are required. So genetic analysis is critical for analysis, for diagnosis and understanding, and imaging is essential for assessing the structural abnormalities, and tritated surgical therapy is required, and further research is required for the expanded cohort. Thank you.
Too many information in 5 minutes.
Too many slides.
Too
like
many
an
slides, too many
express
information.
train.
So, but I have only question, why do not you have shown the pedigree analysis? That is easy to understand for us rather than those letters and number. So have you analyzed the pedigree pattern and the all
Yes,
family
sir,
member?
We have analyzed the pedigree. We have shown in one of the slides that there were, I have shown in the...
No, total tree.
yes, sir. So there
That
were,
was not there.
So the single patient I have not shown, yes.
Yeah. Okay. Thank you. Dr. Anarg. Dr. Anarg from,
He's not here, I don't, was it?
is not there.
We'll go for the next presenter.
Dr. Kollani, then Dr. Brishti Majumdar, then Dr. Shamendra Karkur, and Dr. Ajay Arora, last one. So we'll have next 5. Okay, please.
Good afternoon.
Kollani.
Yes, sir. Good afternoon, everyone. So my study is a comparative study between two surgical procedures as with respect to the management of a congenital superior oblique palsy. I have nil financial disclosures. So superior oblique palsy is a difficult to treat situation even for strabismologists, because in one surgery we have to tackle the head posture, we have to tackle diplopia, both horizontal as well as torsional. And nevertheless in children it is even more difficult. So, but still, NAP has helped us by classifying it in 2 groups, basically into superior oblique tuck and a traditional inferior oblique recessions. But when the hypertropia is a gross hypertropia, the inferior oblique overaction is gross, there is a large superior oblique underaction and a gross torsion, we need to tackle 2 muscles. In such situations, traditionally we do a superior oblique tuck with an inferior oblique recession. But by single muscle, can this be tackled? Yes. If you place the inferior oblique anterior and nasal to the inferior rectus, all the way from LR to all the way at a point 2 by 2 mm from the inferior rectus medially, it can be achieved. So this is the final position of inferior oblique after our surgery. So in this study, we compared superior oblique tuck with inferior oblique recession with a anteronasal transposition of inferior rectus. So we studied for 2 years. In group 1, we had 15 eyes in which we did the anteronasal transposition, and in group 2, there were 15 eyes with the traditional IO recession surgeries. We included all the patients with congenital superior oblique palsies. We excluded all the patients who were previously treated and previously operated. We did a detailed strabismus examination, but our outcome variables were mostly based on the pre-op and post-op hypertropia, ocular movements, and degrees of fundus torsion. So this is the surgical procedure. After a forced duction test, we isolated the inferior rectus, disinserted it from its insertion, and now we are disinserting it and putting it all the way beneath inferior rectus. This is the inferior rectus. We're putting it all the way beneath it at a point, as shown in the earlier images, 2 by 2 mm nasally to the inferior rectus. So statistical analysis was done at 6 months. The mean age in both the groups was the same, about 19 years. This is my Excel sheet. The horizontal strabismus was also present with the congenital superior oblique palsy. 60% of the patient has an esotropia along with superior oblique palsy, and only 1 patient in our study had exotropia. We manage horizontal strabismus in the same sitting as we manage the superior oblique palsy. This is our post-operative results. In both the groups, the elimination of vertical strabismus and inferior and superior overaction, both the groups, the results were comparable, although statistically insignificant. But what was striking in our study was the time required for both the procedures. In the anteronasal transposition, we could finish the surgeries in whooping 9 minutes, whereas group 2, we could finish the surgeries in more than 20 minutes, which is very important looking at we are operating on the children, we are putting the children under general anesthesia. So this is one of our pre-op and post-op pictures with, as you can see, there is a gross inferior oblique overaction which is eliminated post-op, and an abnormal head posture is corrected, as well as the fundus torsion. This is a patient with esotropia and an superior oblique palsy. The inferior oblique overaction is collapsed nicely after the surgery, and this is the patient with exotropia. No intra-op complications were there, but in 1 patient we had a consecutive exotropia of 15 PD, which was managed by prisms. So what was already known is whenever there is a large angle superior oblique palsy, we need to touch 2 muscles, that is from one superior complex and an inferior complex. But when we do a graded large recession of inferior oblique, there is a chance of anti-elevation as well as recurrence and residual squint. But in anterior nasal transposition, what we are doing is we're twisting the inferior oblique in such a way that it is acting as an intorter and a depressor, but it is originally an extorter and elevated. So we're basically turning the inferior oblique into a superior oblique, but it is still sitting in the inferior complex. The inferior nasal transposition has already been published in the literature, but it has never been done in children before. So we did the surgeries in children, and we found that it can tackle the abnormal head posture, it relieves diplopia, it can correct large hypertropias and fundus torsion as well. So it is easy, safe, less time consuming, and equally effective. So when it's children, sometimes less is always more. Thank you.
Thank you. So I have a comment rather for you.
Yes, sir.
Have you taken permission from the parents that you are showing the full face of the patient?
Yes, sir.
Separately?
Yes, sir, we
And
have
then you have to mention in the presentation here, because this presentation will be in the YouTube.
Yes, sir.
So we had serious complaint from the patient side that you have not taken permission. So you have to write a line that you have taken a permission from the patient side, not the.
Yes, sir. Actually, I had mentioned it in the slide.
Just show that slide.
Yes, yes. Please
because
project it.
from the patient side.
Lot of other social factors also, because when the child grows up,
that is
then it's always there that.
Just show that slide because very important. Second slide you show that.
Yes, this is the second slide, sir. We have taken all the consents for the photographs.
Patients you cannot take consent
No,
because
no.
they're all it's.
That is also, no, you have not written this. These data will be shared for academic platform via YouTube. Now this is the problem. So I have already directed the scientific committee chairperson that you have to take, because this is a serious issue, some case will happen. So already there are discussion is going on.
Data privacy.
This
patient
is
privacy.
just standard statement for we take consent from everyone, but we are showing this data to the all world actually.
Public.
All world. In a second, everybody, and when the child grew up, there is a problem. There was actually 3-4 problems we have solved with personal apology letter to the parents. So next time I have told specifically, because Queen you have to show face. Thank you.
But
Yes,
at least
thank
the
you, sir.
mouth can be blackened out, the lower portion.
Then squint that
No,
Head
the,
posture.
because the
that
thing
his
is,
posture, all thing will be like,
Exactly.
even the palsy, Bell's palsy.
with facial recognition software now, it's very easy to kind of
So very difficult.
do a lot
very
of
difficult
things.
nowadays. Anyway, thank you,
Yes.
very nice.
Thank you, sir.
Brishti Masumdar.
Brishti.
Good afternoon to all. I will be presenting my paper on comparison of outcomes in single versus multiple surgeries in cases of open globe injuries. We have NIN financial interest. Open globe injuries or OGIs are a major cause of sudden vision loss, especially in the working age group. The first treatment is always a primary repair to preserve globe integrity. However, further surgeries may be needed for visual rehabilitation. And there is not much literature comparing the outcomes of single versus multiple surgeries in OGIs. The aim of this study was to compare the functional outcomes of single versus multiple surgeries in open globe injuries. It was a retrospective observational study from January 2018 to July 2024. 102 cases of OGIs undergoing single or multiple surgeries at a tertiary eye care institute were included in this study. Cases with less than 3 months of follow-up or undergoing any of the surgeries elsewhere were excluded. Demographic details, number and types of primary repairs and additional surgeries, best corrected visual acuity in logMAR at presentation after the first surgery and at final visit were noted. Cases were divided in 2 groups with 51 cases in each, Group 1 for primary repair only and Group 2 for more than one surgery. Functional outcomes of both groups were compared. The mean age of the study was 24.06 years, mean duration of presentation 54.09 hours, mean initial best corrected visual acuity in logMAR was 2.81 and mean final visual acuity 1.75. Mean follow-up duration was 12.38 months and there were more males in the study. The most common type of primary surgery done was corneal tear repair. Comparing groups 1 and 2, we can see that there was improvement in visual acuity in both groups, with greater improvement seen in group 2, that is the multiple surgery group. However, the p-value comparing the final visual acuity of these two groups was not significant in our study. In group 1, the most common surgery done was primary repair only. Few cases included additional procedures like lens aspiration, vitrectomy, and intraocular foreign body removal. In group 2, majority of cases underwent 2 surgeries, and only 6 cases underwent 3 surgeries. The best corrected visual acuity at presentation, after the first surgery, and at final visit were noted. And the p-value comparing the acuities between these groups was significant, as seen. But the largest effect size was seen when we compared the initial versus the final visual acuity. Cases in group 2 were also divided into procedures involving the anterior segment only and the posterior segment. In anterior segment, the most common surgery done was cataract surgery or lens aspiration with or without IOL implantation. And in the posterior segment, it was retinal detachment surgery with or without lensectomy. In the 6 cases which underwent 3 surgeries, the second surgery involved various procedures like anterior chamber wash, vitreous lavage, or a retinal detachment surgery. The most common indication for the third surgery was retinal detachment. This table summarizes the outcomes. The p-values comparing the mean initial and the final visual acuity was significant for all groups as seen. That is, the single surgery group 1, the multiple surgery group 2, and the individual subgroups under group 2. This is a graphical representation showing greater improvement in visual acuity in group 2. Thus, the final visual acuity of the multiple surgery group 2 was better than the single surgery group 1, although the difference was not statistically significant. And within group 2, the largest effect size was seen when comparing the mean initial versus the final visual acuity amongst all the subgroups. Previous studies include that of Sathers et al., who studied OGI cases undergoing primary surgery with 2 additional surgeries, and they noted greatest gains in visual acuity after the first and second surgery. Gomez et al. Had studied ocular trauma score features in OGI cases and noted better improvement in visual acuity after standardization of anterior segment procedures. Studies have also noted better anatomical and functional outcomes after intervention for posterior segment pathologies in OGIs. Thus, the popular belief that exists among both surgeons and patients that vision may not improve after the first surgery, that is the primary repair, may not be true, as shown by our study. To conclude, the need for multiple surgeries and the outcomes in cases of open globe injuries must be borne in mind while explaining the prognosis of the condition and the outcomes to patients and their kin. Thank you.
So you're basically concluding that multiple surgeries may be better than a single surgery?
Sir, I would be concluding that in cases which require multiple surgeries, the stress for the need of multiple surgeries should be clear to the patient that the first surgery is not for visual improvement. So yes, by our study, I would say that.
But then there are so many variables here because, you know, open globe injuries are not standard. It's not like a cataract surgery or a glaucoma surgery. So there are so many variables. The extent of trauma, the size of the wound, whether other ocular structures are involved, competence of the surgeon. So all these, I think, have to be taken into consideration because, of course, if you have multiple groups of surgeons or different specialties working together, then even during a single surgery, you may be able to give a good result. If it's a single surgeon who's not able to manage posterior segment, he just does anterior segment, then multiple sittings may be required. So there are so many variables when you look at open globe injuries. So I think this conclusion is a little warped in the sense that
Dr. Shamendra.
It's variable.
If I
Thank
can also ask a question.
Yeah,
I think
carry on. Yeah.
just to take extension of what Shri Ganesh just asked, what you feel could be the source of bias in the results that you have presented? That patients requiring multiple surgeries had better outcome as compared to those who required single surgery. Do you see there could be some confounding factor that has resulted?
Sir, one factor could be the patients with whom the multiple surgeries were advised, they would opt for a second opinion elsewhere. So,
Fine, thank you.
Good afternoon, respected judges. My topic is adalimumab in the management of pediatric non-infectious uveitis, assessment of efficacy and compliance. Pediatric uveitis incidence is 4.3 per 100,000 population per year, and it constitutes 20% of all uveitis cases globally. There has always been a need for alternative therapy in children, which reduces steroid burden, induction of early remission and its maintenance, non-daily dosing, and minimizes side effects. The purpose of the study was to assess the efficacy of adalimumab in pediatric chronic non-infectious uveitis and to evaluate treatment compliance. The efficacy was evaluated based on inactivity on fluorescein angiogram and ability to maintain remission without corticosteroids, and Sun classification inactivity was used for anterior segment inflammation. Treatment compliance was evaluated based on simply producing the empty box of injection during next visit. It was a retrospective design, which we are also enrolling patients from now on, and it's like an ambispective design. 14 eyes of 7 patients was analyzed. Patients were below 16 years. The mean age at presentation was 12 years, and there were 4 males and 3 females. The inclusion criteria had children who were cooperative of ultra-wide field imaging and OCT, no prior history of implant or surgery, age below 16 years, no history of prior immunosuppression or failure to achieve remission with the same. Diagnosed to have chronic course of uveitis, failure to achieve remission in the last 1 year without corticosteroids, and no infectious etiology identified on uveitis workup. Exclusion criteria had children who needed multiple immunosuppressives due to associated systemic vasculitis, children not cooperative or fit for ultra-wide field imaging, and previous history of use of adalimumab or other biologicals with poor compliance or default, unavailable history of immunization or active tuberculosis. Disease-wise case distribution was as follows. There were 2 cases of JIA-associated chronic anterior uveitis, 1 with Blau syndrome, 2 of Behçet's-associated panuveitis and vasculitis, and 2 were pars planitis with macular edema. Adalimumab therapy was given as 40 mg of adalimumab for above 30 kg of children, and less than 30 kg we gave 20 mg, and it was given subcutaneously, taught by us, and self-administered at home if chosen. Initial fortnightly dosing for 3 injections, and later the gap was increased based on fundus fluorescein angiogram assessment. The methods were that all patients underwent complete evaluation and uveitis workup and were cooperative for imaging. Infectious cause, specifically tubercular etiology, was aggressively ruled out in all cases. The diagnosis was established after thorough examination by rheumatologist, and the patients were initially started with methotrexate in combination with steroids and followed by biological therapy with adalimumab. All patients achieved remission in between 6 to 10 weeks, except 1 case of Behçet's-associated panuveitis with vasculitis. The mean follow-up duration was 15 months. 2 patients were lost to follow-up after 6 months. However, we continued following them up telephonically and reviewed their images at the local hospital. Mean number of injections received was 7, and all patients received adalimumab in conjunction with methotrexate. There was an acceptable side effect profile, and in the study, we achieved remission in all eyes of 6 patients. Adherence was good to subcutaneous 4 to 6 weekly regimen during maintenance. Only 1 patient experienced manageable side effects like myalgia, anorexia, and fatigue. This is the fundus fluorescein angiogram of the patient where we could not achieve remission despite 12 injections, and we as a trial loaded this patient with IV methylpred for 5 days, 1 gram, and still the picture remained the same, including ferning and disc leakage. Pediatric chronic NIU remains a challenge in view of treatment-related complications because these kids require treatment for decades together. Complications secondary to failure to achieve long-term remission, and with its subcutaneous monthly maintenance regimen, it can prove effective in managing this subgroup of uveitis. Compliance was good. The logs were produced on next follow-up visit. They presented empty injection boxes, and reminder calls were given just to ensure that the compliance is good. Early initiation of biologicals could provide early remission, and adalimumab is an efficacious drug which ensures good compliance due to subcutaneous dosing and less frequent dosing. Thank you very much.
presentation. I just wanted to ask you a few things is that there are several studies of adalimumab in the children, and it's been proven that it's a very safe and effective drug. And there is 2 papers at least from India already published in IGO about the usage of adalimumab. What new information this study is providing? Second point is that your sample size is only 7 patients, and to make a conclusions on the 7 patients is little stretched.
So for first question, the previous study in IGO, it included patients who were on several immunosuppressive therapies, which with adalimumab being a second line treatment, wherever in our study we started the children on adalimumab as a first line treatment. Second thing about the sample size, we were very, very strict with our exclusion criteria, because this is a new drug, and in our setting we wanted to be very sure before we put the patient on long-term therapy with biologicals, and that too because of the financial burden. So we have continued to follow this cohort, and we want to continue adding more patients to this study.
How do you plan space? You cannot indefinitely put on the adalimumab. So what is your plan of tapering down or continuation of the adalimumab?
So there is no clear-cut guideline on when we can stop or taper off adalimumab, but in general, after 2 years of remission, we can consider either increasing the gap between 2 injections, or we can, if the child has crossed 10 years of age, then we can think of stopping it altogether and keep a close watch if the recurrence or
I agree.
happens. Yeah, because there is another study, the ADJUST trial, where they have done this, and they have seen that stopping adalimumab leads to more recurrences compared to the placebo.
Yes, you are correct.
So, last speaker is Ajay Arora.
Thank you, sir. Good afternoon. So I'm presenting a new safe Avastin puncture assist device. We know that particulate matter can be in parenteral solutions, and unintended presence of extraneous mobile and undissolved particles can be either visible when they're more than 50 microns or subvisible if they're less than 50 microns. And they can cause impairment of circulation, blockage of blood vessels, damage to organs, and phlebitis. The incidence of coring with blunt versus sharp needles is variable. The incidence could vary as much as 3 to 97%. We have known that Avastin, which is a multi-dose vial, has been used, and Avastin does not blind people, it's the people who blind people. And we have now needles available for injecting the biosimilars or the Lucentis, Eylea, and other drugs which have got a 5 micron filter. Fractionation methods are available, but compounding pharmacies are not available in India. 80% of the ophthalmologists in India are still using Avastin despite the availability of biosimilars of ranibizumab, and they use directly from the vial. So the question which this paper asked was, when we go through a rubber stopper of a vial with a 26 or a 30 gauge needle, do we core the rubber? Yes, we do. When we use a 5 micron 18 gauge needle to remove drugs from Razumab, Eccentrix, Eylea, do we still core despite using the filter? Yes. If the saliva is less than 5 micron, yes, we still do it. So certain relevant facts, whenever we puncture any bottle which is multi-dose vial, we tend to go through the center of the rubber stopper. We could go from any area of the rubber stopper other than the center. Does this cause aseptic endophthalmitis? It could cause. Therefore, I made a device which looks like this, which has got a central disc which sits over the Avastin bottles. It has got this N1, N2 slots. It has got 2 handles. It is made up of titanium. It has got outer circle which has got 8 holes. Each axis is 45 degrees apart, and an inner 4 holes which is about 22.5 degrees apart. And there's a screwable handle which can sit on the Avastin bottle and the N1 and N2. So therefore, I could go through an Avastin bottle 21 to 25 times without going through the same hole again and again. So these are the possible sites by which I could inject. And a pad allows us to puncture the multi-dose vial without going through the same hole again and again, just by changing the axis from N1 to N2. So this study was done in IIT Delhi. We took 12 rubber stoppers and tested them with or without a pad with 23, 25 and 30 gauge needles. All bottles were cleaned extensively with deionized water, and then 200 microliters of DI was injected into the bottle, either randomly without a pad or in a specific manner by using a pad. Next, these bottles were put on they were examined under the microscope. The fluid was taken with a micropipette and were examined in these wells to understand what is the size of the particles which are visible or not, and then scanning electron microscopy and energy dispersive X-ray microanalysis was done to study these particles. The energy dispersive X-ray analysis basically uses an electron gun to knock off an electron, and then we remember the K11OP orbitals of an atom, from electrons from higher level comes down to a lower orbital and releases X-ray like waves, which can be detected by EDX. So this was tested on a 23 gauge with without a pad, 25 gauge with without a pad, and 30 gauge with without a pad. We found that 30 gauge with without a pad almost had no slivers, which were shown, and this was demonstrated by scanning electron microscopy images. With a 23 gauge, we had 8 to 10 micron size. With a 23 gauge A pad, we could still find the particles. 26 gauge, the particle size was smaller, but the numbers were higher, and this is with the A pad, and this is scanning electron microscopy, a 30 gauge needle without a pad, and with when using a pad with a 30 gauge needle, we hardly could find the particles. We then tested whether these microparticles was a contamination. So we tested on the EDX from the rubber stoppers and the slivers, and we found they produced the same peaks. That means the amount of carbon and oxygen present in this was similar. Therefore, that meant these slivers were exactly coming from the rubber stopper. So this demonstrated clearly that the slivers were produced from the rubber stopper. So this is the first study ever in literature to look at corings produced with a 26 or a 30 gauge needle. It is the first study to look for corings with scanning electron microscopy worldwide. Punching of a rubber stopper generates coring or slivers which have the same composition as a rubber stopper. Larger the lumen of the needle, larger is the size of coring. And this I have demonstrated that by using a pad on a multi-dose vial, one could reduce scoring, and this will have multiple ramifications beyond ophthalmology. We could use it on Avastin bottle, botulinum toxin, xylocaine bottle, bupivacaine bottle, and next would be, if at all possible, if I could inject these slivers into animal study to produce inflammation. Thank you very much.
So, I have only one question to you, that Avastin is a long story in India. We all know that. So why have you kept the kept the Avastin name in the title?
So because
is there any reason? And this is Avastin. I mean, it is a trade name.
So I actually, that's true, but the Avastin bottle, I tested in Avastin. If you see, each Avastin bottle has a red line. That is called the orientation line. So on that,
no, you could write something, the whatever. Normally, we do not use the trade name in the title. Okay. That is my intention of asking you. And where there is a huge noise in India, we know the story of Avastin. That's why I am asking this question. Probably you could use the original. Right. The study is good. That is no doubt about it. But original nomenclature. Right. And another thing, just on humorous side, that APAD you have, this for abbreviation sake you have named it?
APAD.
APAD, Avastin Puncture Assist Device.
No, that's what I am asking. That, in Bengali what is called APAD? APAD is Bangla mein, I'm just over. Rangachari is over. Just for sake I am telling, it is called Apod. Apod means you ask Brishti. Brishti can tell what is the meaning of apod, you can ask. So,
Apada.
Trouble. So I think on behalf of all.
No, this is just for this device. I just for suggestion, you name it, Aurora.
On behalf
For
of
that-
all the judges, I will like to thank all the speaker. I think the
Thank you.
quality of papers was very good. But I'll also request the scientific committee that this presentation should be in a larger hall. This is, we feel sad when people are standing on.
We'll take
You
that
can-
back to the
you can
scientific
come.
committee chair.
You can no. I have serious writing
yes,
here.
so
You
just
probably should read.
from the office of the scientific committee, I would just request that if each judge could come up with a few, not that is back end, that is to us.
No, not back
and
end.
No,
You
no,
know
as
that.
in, I would like the judges to, because a lot of young people here, and those who are potential, so many of them were attending because they wanted to see what kind of papers go to the Colonel Rangachari session. So a few guide tips or guidance on what quality of papers do you look at? So just from each judge, more of that, and then we'll go on to, sir, as you said, the remaining part of it. But more for the young students who are here.
No, so my suggestion that, see, one is presenting on a behalf of an institution. A large, like 40, 50 people are working on it. And you are just presenting that. It is not your work. You are nobody there. You are just a clinician. You have just collected the sample and given to them. And they have given this is for publication. That is a very good thing. But when somebody is working alone, or maybe 2-3 people, we always like that. That is my point of that. What is his contribution or her contribution towards that particular paper? That is very much essential. Then question of innovation comes. That innovation is from institute to innovation is going on. Nothing is with the presenter. Presenter is presenting, that's all.
No, but I think, Dr. Basak, I'll differ a little bit on that. That I think what is most important in a scientific publication when we are looking at Rangachari is the quality of scientific rigor that is shown in the publication. Was the study question very well defined?
Yeah.
Was the methodology chosen by the group or institute or by the presenter was clearly highlighted in the slide? The results are captured which are really leading to conclusions that author has drawn. I think if every one of us very clearly articulate the study question, methodology, and then use the results that they are presenting to draw conclusion. If your result you are presenting are something different, conclusions are something different, then the whole rigor of the science disappears from that. So I think I'll not look into whether it is coming from an institute or an individual or a smaller group. But in these award presentation, it is the scientific rigor that is very, very critical.
Then the question of slide number.
Yeah.
Sometimes
Obviously that
5
is a-
minutes, to my calculation, it is maybe 10 or 12 slides. Then you could do justice. Because opposite side, I could not understand anything.
Yes.
Yeah.
That is another point. And the panel is like different. You know, the 3 people from cornea, one from uvea, and one is cataract refractive. What are the other panels?
No, so this is another suggestion. I think other than what the scientific rigor and the selection, my suggestion will be in future, I think, from each specialty that you pick up best paper, those should be represented here as a judge.
Yeah.
Because then they will be able to do justice as far as evaluating the quality of the content and the question.
Right.
My point is, I look for the novelty.
Yeah.
I look for the innovation in the paper which is coming up, not the questions which is asked is that something new which is asking. There's a good way to look into some novel ideas and questions. You can look into the investigative ophthalmology and visual sciences, scientific posters, which is presented over there, which is freely available. You can look at that one all over the world. The innovative idea is the first fresh ideas is presented over that. They can get a clue from that one. And then you take not too many objectives. Take 1, 2 or 3 objectives and then try to get that results and put in the proper perspectives. Then taking too many objectives, too many pictures and all focus on one area or 2 areas and solve that problem so that you can come out with the suggestions and can have practical implications in the day-to-day management.
I think.
No. Ganesh.
Yeah, I think the content is important. The scientific content is very important. So you will have to decide what you want to present and how it's going to help the scientific community in improving their practice or in bringing something new to help patients. If it's not going to help patients, then it is useless. If you just have some statistics and present it, so the content, why you're doing this study, the research question, and then what was known, what you're contributing in terms of the literature to the scientific content is very important. Presentation again is very important. It should be like telling a story. It should be very clear, and the audience and the judges who are listening, there should be some amount of time for them to understand when you present something. If you have too many slides, if you have 40 slides which you want to present in 5 minutes, you can do it, but you're going through it so fast we can hardly see the images, we can't even comprehend what is being said. So please don't use more than 10 or 12 slides. If you want to be on time, you can put it in a slideshow so that the time is fixed to 5 minutes and you rehearse so that the slides automatically change and by 5 minutes you're done. So it's very easy to do that. So the presentation has to be very good. The slides also should not be cluttered, because I saw some of the slides, there's so much of content there, you can't actually go through that in like 20 seconds, because all we need is like 10 to 20 seconds to go through that. And if there are too many photographs, if there's too much of content on the slide, maximum 5 lines. So it's going to help you to kind of tell your story. Or one image, not 20 images there, 1 or 2 images.
No need of unnecessary ornamentation. Yes. Just give the science.
And originality is again innovation. How original is your idea or your innovation, whether it has been done before, whether it has been published, whether you're contributing anything different to that, or whether it is completely original and it brings something very new to the scientific community. That is very important. So on these things we mark. And time. Please keep up to time, because once you cross over time, then there's a time bar. So that is something that you should keep in mind. So with these things in mind, you can make the presentation. I mean, we may not be experts in that subspecialty, but overall we know what is the quality of the scientific presentation, the content, how it is presented, all that we are able to judge. Okay, and sometimes there are huge gaps in methodology. Okay, methodology is very important, because if your methodology is warped, your results go out of the window. So the methodology has to be very sound.
Conclude. So thank you very much. We conclude